Welcome to the Getting Ready for the Maryland Primary Care Program General Program Update. I'm Chad Perman from the Maryland Department of Health, Project Manager for Maryland Primary Care Program, or MDPCP. I'm joined by Dr. Howard Haft, Deputy Secretary for Public Health Services and Executive Director of the Program Management Office. I am also joined by Alice Sawinski-Rice, who is the Analyst for the Program Management Office. Thank you for taking time out of your busy schedules to spend time with us. Today we are going to provide an update on the status and the components of the Maryland Primary Care Program. Let's just review a few logistics and housekeeping items before we get started. On your screen you should see the presentation, Getting Ready for the Maryland Primary Care Program. Along the top of the screen you should see administrative options, including if you have a question or dial-in info if you get disconnected. All lines have been muted besides the presenters. We will be monitoring questions that come in as we present. At the end of the presentation, we will field submitted questions. If you have a question, please click on the Question tab in the box on the right. Also, we will be posting a recording of this webinar on the MDPCP webpage at MDH for future use. A couple of final reminders. Please do not put your phone on hold. We know what happens with that. And also, please put your phone on mute. Before I walk through the slides, I would like to ask Dr. Haft for a few introductory remarks.
Chad, thank you very much. And I'd just like to start by saying thanks to the very many participants and stakeholders over the last several years who have given generously of their time and talent to put together what is the Maryland Primary Care Program that we're now able to present to you. This voluntary program will bring both financial and technical resources to our primary care providers across the state to allow them to transition to advanced primary care with an intense focus on care management. This is a major program that can effectively improve the care and outcomes for our patients, as well as improving the quality of life for our providers, in particular primary care providers across the state. As a primary care provider myself over the last 40 years, I can tell you that I have never seen a program comparable to this one in terms of its impact on and benefit to both providers and patients. So I encourage you to be thoughtful and careful in your decision-making process and listen carefully to the presentation. We'll be more than happy to answer any questions you have as this program unfolds. Thank you very much.
Great. Thank you, Dr. Haft. Now we're going to go through the presentation. We'll be reviewing a few key topics before we move into questions and answers at the end. First, program overview, and then care delivery redesign, as well as payment redesign, supports for the practices, eligibility and restrictions, and the timeline for the program. The state and CMS have negotiated a total cost of care model, which is an expansion to our current all-payer model. The model is aimed at improving health, enhancing patient experience, and reducing per capita cost. The total cost of care model, as you see here, is the umbrella structure for health transformation in Maryland. The total cost of care model builds on the successful hospital global budget model that started in 2014. So there are as you see here, there are three core components of the total cost of care model laid out in the visual. First is the hospital global budget model on the left. Then you have the care redesign programs. There are two of those, also known as CCIP and HCIP, which establish financial and delivery partnerships between hospitals and providers. And finally, the program that we are here to talk about today, and the newest, is the Maryland Primary Care Program. The Maryland Primary Care Program is an exciting opportunity for Maryland to increase focus on prevention, chronic disease management, and population health, and it will be effective January 2019. So how is CPC Plus different from MDPCP? MDPCP builds on an already approved CMS model known as Comprehensive Primary Care Plus, or CPC Plus. However, it differs in several important ways outlined in this table. MDPCP is a component of the total cost of care model versus CPC Plus, which is an independent model. There are no cap on number of practices in MDPCP, and there will be an annual application period. In addition, practices must migrate to Track 2 by the beginning of the 4th year in the program. And in addition to payment redesign, MDPCP also adds in care transformation organizations, or CTOs, which we'll talk a little more about later. Medicare fee-for-service and duals are eligible to participate in the Maryland Primary Care Program, but other payers will be encouraged for future years. So let's talk a little bit about the requirements for the program, starting with the primary care functions. MDPCP includes specific care delivery changes. The principles of care redesign are based on CMS's 5 primary care functions of advanced primary care. The following slides are an overview of care transformation requirements for the program. Practices will be asked about their capabilities in these areas when they apply to participate in the program. There are 5 primary care functions or domains, and then specific care transformation requirements underneath that practices must demonstrate progression on along the way. The 5 functions are access and continuity, care management, comprehensiveness and coordination, beneficiary and caregiver engagement, plan care, and population health. The requirements under the primary care functions must be delivered to Medicare fee-for-service beneficiaries at a minimum, but in reality, many of these requirements will likely occur for your entire patient population. Start with access and continuity. The first function that you see here, we display the Track 1 requirements and then the Track 2 requirements, which include the Track 1 requirements. As noted earlier, the MDPCP is based on the CMS CPC Plus model. As such, it has 2 tracks, a standard track, or Track 1, and an advanced track, Track 2. The access and continuity requirements address a patient's coverage by a care team and access to his or her health information. Practices will be expected to impanel patients to care teams, meaning practices take responsibility of assigning patients to a care team, which is a group of individuals at your practice led by a practitioner who work together to care for a specific panel of patients. The care team should also be providing 24/7 coverage, including patient access to electronic health records. For Track 2, practices offer alternative visits, such as e-visits or group visits or telehealth or even remote monitoring. The second domain is care management. Practices will be expected to identify and prioritize a methodology to risk stratify all of their impaneled beneficiaries. Practices would be expected to use a defined algorithm or process or tool to do that. Practices will be expected to ensure all beneficiaries identified as increased risk receive targeted, proactive, relationship-based longitudinal care management. Practices will also be expected to ensure patients receive a follow-up interaction from their practice for ED and hospital discharges. And practices will be expected to target patients who have received follow-up after ED and hospital discharge or other triggering events to receive short-term or episodic care management. In Track 2, practices will ensure patients receive longitudinal care management, which is engaged in a personalized care planning process, and also have access to comprehensive medication management. The third function is comprehensiveness and coordination. This set of requirements is about the ability of the practice to address the majority of needs of its patients and coordinate services with other providers. Practices will be expected to identify the high volume or high cost specialists and organizations using payer data, and then ensure coordinated referral management. Practices will also integrate behavioral health into their functions, and several options will be provided in the program to choose from. In Track 2, practices will address social needs by facilitating access to resources that are available in your community for patients with identified health-related social needs. The fourth function is beneficiary and caregiver engagement. In Track 1, practices will be expected to convene a Patient Family Advisory Council, also known as a PFAC, at least once per year, and then integrate those recommendations into care and quality improvement activities. In Track 2, practices will engage patients and caregivers in a collaborative process for advanced care planning. The final function is planned care for health outcomes. The functions and requirements under here are the same for Track 1 and Track 2. And these requirements are about using data to plan care and using data to perform quality improvement in your practice. So for both tracks, it will be incumbent on the practice to continuously monitor and improve performance on key outcomes, including cost of care, electronic clinical quality measures, patient experience, and utilization measures. In addition to the care transformation requirements for the program, there are metrics, quality and utilization. On quality, practices must successfully report at least 9 of the 19 ECQM measures. More detail on the preliminary list is provided in the appendix of the slides, which we sent out earlier and will send out and make available again. Practices must report both outcome measures. Those are diabetes control and hypertension control, and at least 7 of the remaining 17 process measures. 75% of your overall quality score is made up of the ECQM performance, and the remaining 25% is comprised of patient satisfaction. Utilization will also be measured, and will be measured for ED visits and hospitalizations per 1,000 Medicare fee-for-service beneficiaries that are attributed to the practice. These are measures that drive total cost of care. The utilization measures do not require reporting on the practice's part. So in addition to care delivery redesign, MDPCP significantly changes payments. There are 3 payment streams for practices. 2 are prospective payments. The first, and perhaps most significant for population health management, is the risk-adjusted care management fee, or a CMF. You see this on the left side of your screen. The CMF is intended to support augmented staffing and training related to non-visit based and historically non-billable services. These include activities to improve care coordination, implement data-driven quality improvement, and enhance targeted support to patients identified as high or rising risk. These are care management dollars for all attributed Medicare fee-for-service beneficiaries in your practice. The care management payments are designed to allow practices to address the varied needs of the Medicare population and embed resources necessary to manage the health of your practice population. The CMF in Track 1 ranges from $6 to $50 per beneficiary per month, or PBPM. $15 is an average that has been used in the CPC Plus program, but each practice will look a little different. It's important to note a few things. The CMF is akin to the chronic care management fee, which is currently billable in CMS. As such, practices cannot bill both for its attributed beneficiaries. The CMF is a prospective monthly amount that covers all fee-for-service beneficiaries in the practice. In the second stream here for Track 1 is the performance-based incentive payment. This is a bonus for practices also paid PBPM. It is paid upfront at the beginning of the year for all attributed beneficiaries for both quality and utilization. Depending on a practice's performance, CMS may require repayment or some of all or the money after the annual performance period. In Track 1, the PBPM is $2.50. Finally, on the right side of your screen, practices will continue to bill fee-for-service reimbursement in Track 1. In Track 2, it has the same payment streams for practices, but at a higher level. The major change for Track 2 payment is in the payment structure on the right side. Practices must accept a hybrid payment called a comprehensive primary care payment, or CPCP. CMS will use the hybrid payment that will allow practices the flexibility to deliver care. The comprehensive payment is meant to allow practices to innovate and to redesign how they provide care. The upfront comprehensive payment component of the hybrid payment compensates the practitioner for transitioning clinical services that have traditionally been separately billable office visit, evaluation, and management services to commonly non-billable care delivery modalities such as telephone calls or secure messaging. CMS will offer several options to choose from, ranging from 10 to 65% of the practice's historical E&M billing. and the rest will be billed as fee-for-service. Now we turn to supports for practices. First is the Care Transformation Organization, or CTO. CTOs are an innovation in the Maryland design to assist practices meet the care transformation requirements. Using a CTO is optional for all practices. CTOs provide services in 5 main areas: care coordination services, support for care transitions, data analytics and informatics, standardized screening of beneficiaries, and assistance with meeting the care transformation requirements. The CTO is intended to extend resources and services to practices that may be hard for practices to employ or coordinate otherwise. Resources envisioned include care managers, community health workers, social workers, pharmacists, behavioral health counselors, nutrition, etc. CTO's role in the program is CTOs will be providing services that are integral to meeting the care transformation requirements, but do not require the personal professional services of a physician, meaning CTOs will provide services under incident to a supervising provider at the practice. The CTOs will enhance capacity for the practice, and they will also embed resources at the request of the practice and or provide services to patients in the community. On this slide, we outline additional supports for the practices. Practices will be offered health IT tools and supports through several avenues, including CRIS, the State Designated Health IE, the MDPCP portal, and their CTO's tools and analytics, should a practice be using a CTO. CMMI will also provide learning system supports to educate practices on how to transform and how to meet the care transformation requirements. The state will also have additional supports on practice transformation. The MDPCP data tools are here on this diagram, and here are the different data tools and resources that are planned. CMMI will be providing an MDPCP portal for practices to report on progress through quarterly surveys and receive data and feedback from CMS. CMMI will also provide access to MDPCP Connect, a system for program participants to receive education on transformation, as well as connect with each other and share best practices. Practices should also leverage their own EHRs to fulfill the program requirements. Use of CRISP is integral to the success of the Maryland Primary Care Program. CRISP will be providing a portal specific for MDPCP participants, providing access to many different resources. These include current services that CRISP offers today, social needs information, a quality reporting mechanism for the ECQMs, claims data on your attributed population, and as noted here, CTOs will also be providing their own tools and analytics at the request of the practice to help with practice transformation. The tools outlined here for CRISP, we will have more information on later as that's in development. Now, to talk about eligibility and restrictions, let me turn it over to Alice Sawinski-Rice.
Thanks, Jeff. So I'm going to quickly take us through the eligibility and restrictions for participating in the program, and then I'm going to go over some highlights for what the upcoming timeline is going to look like. So in order to participate in MDPCP, there's a few things that practices need to do to be eligible. First, they have to pass a basic program integrity screening to make sure that the practice is in good standing with CMS. There's also a requirement for practices to have a minimum of 125 Medicare fee-for-service beneficiaries that are attributed to their practice. Practices have to use a certified EHR, and since applications are going to be submitted for each individual brick-and-mortar site, the practice has to be physically located in Maryland. As part of the application, practices will also be required to submit letters of support from their clinical leadership and the owners of the practice, and those letters will basically indicate their commitment to participating in the program. And practices will also need to get a letter of support from CRISP, confirming that they're working with CRISP and able to exchange data. Beyond those basic eligibility requirements, practices are going to need to demonstrate that they can meet the overall care requirements for the program as part of their application. So for track 1, this means having experience with certain types of practice transformation activities like assigning patients to a practice panel, providing 24/7 access, supporting quality improvement activities, and also risk stratifying their patient panel. Keep in mind that for track 2, practices are going to need to move into track 2 by the beginning of their 4th year in the program. So they're going to need to be able to meet all the care delivery requirements for track 2 at that point. So specifically, that means they're going to need to have the ability to offer alternative options for care delivery, and they're also going to need to be able to accept hybrid payments in order to receive the CPCP payment stream, which is the comprehensive primary care payment. There's also a few requirements that are specific to HIT that are required for participation in the program. So as mentioned earlier, practices need to utilize a certified EHR, and they also have to be able to connect to CRISP. At the point where they are getting their letter of support from CRISP, they're going to have to commit to bidirectional data exchange by the end of their 1st year in track 2. For quality reporting, Chad already talked about how there's 19 measures that practices can choose to report on. So in order to do that, practices need to be using the latest ECQM specs for all the measures, and that will include the annual updates. And practices will also need to be ready to report on the measures electronically to CRISP, either directly through their EHRs or through the CRISP portal. So now that we've gone over some of the high-level eligibility criteria and requirements, I want to make sure that we mention that there's a few restrictions or exclusions that would keep a practice from being able to participate. So first, a practice cannot charge any concierge fees to Medicare beneficiaries. And there's a few other CMMI initiatives in which payments would duplicate or conflict with MDPCP payments. So if you're a participant in one of these models, you would be excluded from participating in MDPCP. So these include the ACO investment model, next generation ACOs, and also the comprehensive ESRD care model. Practices are also going to be excluded if they're a rural health clinic or an FQHC. But one caveat here is that the rural health clinic or FQHC itself is not eligible to apply or participate as a practice site in the program. But if a clinician spends time at both an FQHC and another primary care location that would qualify, then they can participate in MDPCP through that other location. So with that, I'll give a very brief overview of what we expect the upcoming timeline to be, and then we can move on to questions. So we expect that CMS is going to be releasing a request for applications in very early June. So keep an eye on the CMS website because we expect it to be posted there in the very near future. After that, both CTOs and practices are going to submit their applications. So the application period is going to run through the end of the summer or early fall. Once they're selected, both CTOs and practices are going to sign participation agreements sometime in the fall, and then the program will officially kick off January 1st, 2019. There's going to be an annual enrollment period for new practices to sign on through 2023, and then the program is going to run through the end of 2026. So with that, I think we can stop there and see what questions have come in.
Great. Thank you, Alice. I hope that was useful for everybody. We are just pulling up the questions now. The first question is, can you provide more details on the application process and timeline? Dr. Aft?
Certainly. We anticipate that the application will be posted on the CMMI or CMS website early in June, so within the next few days. So I would, at this point, just say keep your eyes open for that. It will be open for the CTOs, the care transformation organizations, to apply first, and that application period will run from the beginning of June through the middle of July. Following the closure of that, there will be a selection of care transformation organizations, and in the beginning of August, practices will be able to do their application process. They'll be able to do that with the knowledge of which care transformation organizations have been selected. So if they choose to select a care transformation organization, which is at their option, they can so do. They'll be encouraged to select 2 care transformation organizations, a first and a second choice. Their applications will be, portal will be open through the month of August and then closed, and then subsequent to that, there'll be a selection process for the practices. So by the beginning of November, practices will be notified of their selection and of their care transformation organizations. We'll then go through an onboarding period, and the program will begin in earnest on January 1st of 2019. Very exciting time.
Great, thank you, Dr. Heft. And one thing to add to that is, as we expect that the request for application will be released in the next few weeks and into early June, we expect that CMS will make that available online, a full application in print. That's a single application for both the practices and the CTOs. Actually applying to the program will be done through an electronic portal, one for the CTOs and one for the practices. All right, Alice, do we have other questions?
We do. So there's a couple of questions around the advanced APM aspect of the program. So I'm going to read them as a group, and then we can just kind of discuss the AAPM aspect. So first is, does either Track 1 or Track 2 qualify as an AAPM? And then can you discuss the aspect of the AAPM program? Do you still have to submit data through MIPS? Will it be treated like an MSSP Track 2 or 3, which still has to do the ACI, or like a next-gen ACO, which only reports quality through the ACO?
So, Alice, thank you. Those are great questions to whoever has posed those. And as you all know, this is a complex matrix of decisions and nodal points. The program is considered an advanced APM under the MACRA rules. It would also be an APM under the MIPS rules, and that will be largely guided by the qualifications of the particular practice. So a practice, for instance, that is in a group that the parent organization is larger than 50 would not fall under the AAPM, advanced APM, it would fall under the MIPS APM rule. There may be other opportunities for those providers, however, to gain MACRA status through other programs that the state has provided, or if they're in an ACO, that it has substantial risk. So I think that is the initial level. So the understanding is that this program is an advanced APM, but depending on the particular provider's situation, whether they're in an ACO or they're in a large group practice, may dictate their ability to access MACRA directly through the program.
Yeah, and let me just add to what Dr. Heft said, which is when a practice is both in the MDPCP and a Medicare Shared Savings ACO, the practice will be evaluated for purposes of MACRA based on the ACO and whether it is bearing risk. So our understanding is that practices in a Track 1 plus, a Track 2, or a Track 3 Shared Savings ACO could potentially qualify under the ACO. The Track 1 doesn't bear risk, and thus the practice won't be eligible for MACRA, the MACRA bonus.
We also have some questions around payments. So when will the prospective PBIP be made, and also some of the other payments?
So another good question, the PBIP, the Performance-Based Incentive Program payment, is made at the beginning of the year. It's made prospectively. It's made for the year. The care management fees, which are also on a per beneficiary per month, are paid in advance on a quarterly basis. As are in Track 2, the comprehensive payments are paid in advance on a quarterly basis.
That's correct.
Questions around CTOs. I believe we touched on this, but are practices required to use a CTO, and then is there a cost to utilizing a CTO?
Great question. The use of a CTO is entirely based on the decision of the practice. There is a cost for using the CTO, and the cost is that a sharing of the care management fees up to 50%. So it would be a 50% share of the care management fees, not of the performance incentive payments and not of the comprehensive payments, only of the care management fees. 50% share would be if the CTO, the Care Transformation Organization, provides all of the support services, including a primary care manager. And 30% if the practice provides the primary care manager and the CTO just provides those wraparound services. For all of these answers, there'll be more detail available on our website and in FAQs to follow.
And one additional note is that all the payments noted in this program come directly from Medicare, whether they are going all to the practice or partially to the CTOs. Medicare will make those payments, so practices will not have to be figuring out a way to share their care management fees and physically pay the Care Transformation Organization, should it elect to use one.
Okay, thank you. Another question is around defining a care panel. Can this be a clinician and support staff? Is this similar to an individual assigned team for high-risk patients, like patient-centered medical homes?
So if the question is, if I understand it, in terms of team-based care, how does the support go for the team? I think that those support teams are configured according to the needs of the patients and the practices. We do anticipate that there'll be a focus on including some pharmacy input. Some behavioral health input is absolutely required in the care teams, and then care management supports for the patients. But exactly the configuration in terms of the ratios of pharmacy support or behavioral health support or care managers will depend on the size and scope of the practices and the needs of the patients.
Okay, thank you. I think that answers the question. There's also some other ones around the 24/7 access requirement. Is this requirement simply to the patient record or to other provider services?
So the access is that there is someone continuously available for those patients who has access to their records, and if not a direct member of that person's care team, is connected to that person's care team so that they can pass on information in a reasonably short fashion about interim care that's provided on the off hours.
Good questions.
Okay. We have another question around, will the social needs resources in the CRISP portal be accessible by the patients themselves or just the providers?
That's a great question. I think we anticipate to begin with these will be available to the providers, although the providers will be likely giving information back to the patients in some written form. There is an anticipation that sometime in the future that more information will be available directly from CRISP to providers, although there's no set time frame for that. I'm sorry, from CRISP to the patients, and there's no set time frame for that.
Another question around, how will this system potentially affect skilled nursing/rehab centers?
So at this particular time, there is no direct connection to our skilled nursing facilities, although there's an expectation that care providers and the teams will be following and monitoring their patients that are attributed to them, no matter what part of the healthcare delivery system they happen to be in. So there's no direct connection to skilled nursing facilities at the start of the program. I think, again, that is something that's probably aspirational for the future.
We also have some questions around eligibility. So would a hospital-based pediatric practice be eligible to participate as long as the vast majority of patients are insured through Medicaid?
No, at this time, Medicaid is not a participant in the program, with the exception of those dual eligibles of both Medicare and Medicaid.
I've seen a few questions come in around this topic, so wondering if we could talk just about it broadly. And it's around the use of a certified EHR. So who will be certifying the EHR, and could any EHR be used by the primary care provider?
So the EHRs are certified through a national process. EHRs must be at least under the 2014 edition of certification to start the program. And most EHRs that are available for primary care practices are certified, but that would be the expectation. Moving forward, as rules change under CMS and the quality payment program, practices as available may be required to move to 2015 certified EHR.
Question on clarification around timelines. Did you say that the application for CTOs and practices will come out at the same time, or will the CTO applications come out first?
So the CTO and practice application will be released at the same time. However, the deadline for application will be first for CTOs. We believe that'll be sometime in mid to late July. Then after that, the actual application online to apply for practices will open up sometime probably in August, and then there will be a period for the practices to apply. However, prior to all of this, the practices can be reviewing the physical application, which will be mirrored on the electronic version that they'll need to submit. And we recommend that you do that and begin to prepare as you think about the program and for the type of information that you would need to submit in the electronic application.
Thanks for clarifying that. A few more questions around ACOs. So if a practice is already in an ACO, can they get out to get into the MDPCP program, and how will they determine which is the better option for them?
So practices are certainly free to elect to be in or out of their ACOs. There's no, except for the exclusions that were previously mentioned in terms of NextGen and other ACOs that are prohibited, the practices are prohibited to be both in the Maryland Primary Care Program and those. For the other MSSP program ACOs, there is no prohibition to be in both. The decision to leave an ACO would be an individual decision that the practice would make. The distinction there may be, in terms of the decision-making process for a practice, that if a practice is in an ACO, it would not be getting the PBIP, the per beneficiary incentive payment, for from the Maryland Primary Care Program. It would be available to get whatever shared savings there are from the ACO, but would not be available to get both. Also, a practice that's in an ACO, all of the care management fees that are going to that practice will be counted toward that ACO's total cost of care. So those are the two financial considerations that would go into to be in or out of the ACO. The other consideration would be the eligibility for MACRA, assuming that it's a practice that is, the parent organization is less than 50 providers.
One other consideration would also be reporting. So practices that are both in MDPCP and Medicare Shared Savings ACO will not be required to report the quality metrics under the primary care program, but instead will be required to report measures under their ACO, and which goes along with not receiving the performance-based incentive payment.
So in summary, I think the decision about whether to be simultaneously in an ACO and a Maryland primary care program would be a very individual decision each practice would make depending on its size and configuration and other considerations, including financial considerations.
Okay, thank you. We also have a few questions around patient attribution. So how will, what is the methodology behind patients being prospectively attributed to a practice?
So patients are attributed to the practice based on several features. One is the plurality of visits over the prior 2 years, but there are other features that will also trigger attribution, such as if a recently done annual wellness visit or a CCM fee that was done prior to the program. So that would trigger attribution to the practice.
There will be more details on attribution, the exact methodology, released as we get closer to the program, but as Dr. Haff pointed out, is prospective attribution based on the past 2 years.
Sort of a similar question around attribution related to patients. If a provider sees patients in multiple sites of the practice, should he or she be included in both practice site applications or just one site?
I think on that one, we can make sure we get a clear answer on that. I believe we have the answer, but we want to make sure we have the right answer, and we'll get that back as to whether you would be listed on both rosters.
We also have a question around the Patient Family Advisory Council. Who has to be on it, and what is the role of this group?
So the Patient Family Advisory Council is made up of representatives of the patient panel that from the practice. There is no hard and fixed configuration. It would depend on the configuration of the practice and be fairly representative, and it would include also providers and potentially staff from the practices, including care managers. And the role of the Patient Family Advisory Council is for the council to give good input to the providers about things that they think that are working well and things that are not working so well. Sometimes also to do surveys of the practice that are different from the external surveys, and then also to demonstrate how to the practices how self-engagement can be done in a better way, self-learning for the patients and for their families. It's a way of uniting the practices and the families outside of the clinical exam room and in a different setting, and getting more varied input. I would say on a personal basis, my experience with these is that they're extremely valuable to the practices, because you never know what other people think about you until you ask them those questions.
We also have some questions around support staff for the practices. So do support staff have to be hired for each site or for the practice itself? For example, our practice has 6 sites in Maryland. Do we need a pharmacist at each site? Do the support staff have to be hired at each site or for the practice as a whole? For example, yes, that's the end of the question.
Each practice site, each physical site is its own entity for the program. There can be shared services for things like pharmacists who you may need to only have a few hours or a part-time, depending on the size of your practice, for that pharmacist. So that is a shareable sort of entity. There is a ratio of in general speaking, care managers, it would need to be sufficient care managers to provide the necessary services to the patients. Each site would need to have some access to behavioral health. So that would either be a behavioral health specialist, a primary care doctor who's been trained as a behavioral healthist, if you will. That might not be a real word. Or a co-located behavioral health specialist is a psychologist, psychiatrist, or LCSW. So some things can be shared, other things would actually need to be present within the practice. It may not need to be present 40 or 60 hours a week, but would need to be present within the practice.
Okay, thank you. That actually leads very well into our next question. If you could define a bit more clearly the components for behavioral health integration, and could this be through a contract with a behavioral health provider, or does it have to be with the primary care practice staff?
So the requirements for behavioral health are that either there is someone within the office who can serve as a behavioral health specialist who's been trained and takes on that responsibility, or that there is a co-located behavioral health. That person could be contracted from someone else, but it would need to be co-located. There is an open question of whether that could be done through telebehavioral health, and there'll be more information to follow on that.
Another question around, is this the program application for a practice, or does the practice have to enroll each doctor/nurse practitioner separately?
Very good question. This is a practice level program, so all applications come at the practice level. Then practices are looked at for the combination of their TIN, their tax ID, and the MPIs in the practice. So the application will ask you to list all providers who are in the practice. So it is at a practice level. I should also note that the types of providers will be outlined in the application, but those include all of your traditional primary care providers, including general practice, internal medicine, geriatrics, family medicine. It also includes OBGYN, pediatrics, and co-located psychiatry.
Question going back to payment again. If you don't meet the quality or utilization targets in Track 2, do you need to repay CMS some of those fees?
So the quality and utilization metrics apply both to Track 1 and Track 2, and depending on the performance of the practice on its quality measures as well as its utilization measures, it may have to repay some or all of that. In order to receive payment on the quality portion, which is half of the $250 or $4, a practice must meet at least the minimum benchmarks for quality.
As a footnote to that, the quality is judged against national benchmarks for the program. The minimum requirement is to achieve a 60% level.
We have some questions around data. So how will practices access claims data? Is it downloadable? How often are reports updated and refreshed? So
data will be provided on request from CMS via the state on the claims data. We expect to have reports and dashboards available in the program. It will start out at a high level and initial set of reports for practices with benchmark comparisons, and then we will, as the program goes on, we'll add more to that. Practices will receive it on all of their attributed Medicare fee-for-service beneficiaries.
Is there any specific training or certification that's required for care managers? Is a nursing degree required, or could it be someone with a health and wellness degree?
There's no nursing degree required for care managers, only that they are capable of providing the services necessary to perform those care management services. They need to be a clinically oriented individual who will be under the general supervision of the primary care provider.
A couple questions around this topic generally, around connectivity to CRISP. Is this dependent on EHR compatibility or something else? If you could just talk more about the relationships that practices need to have with CRISP.
That's a good question, and we know that EHR compatibility is an issue for some practices, depending on the vendor they're using. Practices in their application will be asked to submit a letter of support that they receive signed from CRISP, and in that letter it will affirm that a practice either has a participation agreement already with CRISP or will have it prior to the beginning of the program. And it would also commit the practice to, by the end of the first year in Track 2, that they move towards bidirectional connectivity. We are leaving that open at the moment, so that we don't specify the exact level of connectivity for the practice, knowing that each practice will look a little different. But the idea here is that practices will be exchanging clinical data by the time they are in Track 2. So I think we may have gotten through all the questions. Great questions. And we welcome you to continue to submit questions at our inbox, which is available on the website that you see now, health.maryland.gov/MDPCP. We'll be available to answer more questions in the days ahead, and look forward to working with you and helping you help the state as we take care of beneficiaries in Maryland.
Yeah, thank everybody for your participation tonight. Again, I think that this is one of the best programs that I've seen in many years of seeing changes in healthcare, and I just encourage you all to take a careful look at it, see if it's right for you, and also encourage you to talk to your colleagues if they weren't able to join on the call tonight. We'll have more similar kinds of presentations over the weeks and months to come, and it's just very important that everybody, every primary care provider in the state, take a careful look at this and see if this is right for them. I believe that it is, but those are very individual and unique decisions that we all must make. Again, I thank you very much for your participation.
Thank you all.